I will be talking to you about the application of ICG fluorescence in minimally invasive and robotic oesophagectomies. You're probably familiar with ICG, as it does have a number of applications also in all the branches of surgery. ICG, indocyanine green, can be injected anywhere in the body intravenously. It will be bound to the albumin, and then when it will respond to fluorescence light with the very strong green signal that is acquired by a number of devices, both laparoscopic or open surgery, and obviously will show up on our monitor. Let me minimize this because ICG does have a number of advantages compared to other ways of fluorescence, let's say. First of all, it's incredibly cheap and safe. And with the, let's say, the latest generation endoscopic stack, it will be available pretty much in every operating theater. Another advantage is obviously there is no radioactivity associated with it. The allergic reactions are incredibly rare and dose dependent. The biggest weakness, in my opinion, of the ICG is the quantitative assessment. And this applies specifically when we talk about ICG perfusion of tissue. In esophagogastric surgery, we have a number of problems, as you well know. And this is, I don't know if you can read, but this is the most recent publication on the epidemiology of complication after esophagectomy. As you can see, I've highlighted in green the field of application that ICG is currently in use in my practice. So in the diagnosis of chylothorax, or the prevention of chylothorax, specifically in the identification of the thoracic duct, as you can see, we have chyle leaks in over 10% of the patients. Bronchopulmonary fistula, meaning injuries of the airways, that although is a very rare complication, it is a catastrophic, can be a catastrophic one. And on the right, you will see anastomotic leaks that, in the literature have been reported, from going up to 25% to less than 10%. Chyle leak has been the focus of, in a way, my work with ICG since 2017, when we start working on a trial called the FLOTTER trial, together with Tom Barnes and Richard Gillis. I've told you the incidence is just over 10%. It does have a huge clinical implication because in the severe chyle leaks, patients lose more than 2 liters of chyle per day. With time, it will lead to serious immunological deficits. It does have a number of issues in terms of treatment options because it's not easy to fix, to stop a severe chyle leak. So you can approach this surgically, and it's never easy, or more recently with interventional radiology that is proving to be very effective, although not free of challenges. And it does have a big cost implication. First of all, because these patients who leak quite a lot of chyle every day end up staying in the hospital for quite a few days. Obviously, they will be on TPN, and there will be the cost of intervention. So overall, it does have a big cost implication. And on the right, you will see our chyle leak pathway, that has been developed at the same time as the FLOTTER study. And you can see, we always have a diagnostic test that is the dose of triglyceride in the chest drain fluids. We go through at least a 5 days trial of low-fat diet. Then if there is persistent leak, we switch to TPN. But if a patient has more than 2 liters a day from the beginning of the operation, then we always consider intervention at the beginning. This is the reference to the FLOTTER study published in Surgical Endoscopy in 2022, but we did start working on it just before COVID. And this is I'll show you a video of how it's done, and I'll go through this. So I hope it starts. Yeah, so the procedure is very, very simple. You only need a needle, endoscopic needle injector 2 mL of indocyanine green. I use, as you can see here, the shaft of a laparoscopic instrument just to help the injection. Through the pleura and at the beginning of the procedure, you will see a very faint green. But this is what is kind of made a big change of this procedure, because the injection in the mesentery, it is most of the time sufficient, but it can certainly be improved with the high ligation of the thoracic duct. So we are in the upper mediastinum here, and I've applied 2 hemolocks to the thoracic duct. The circulation in the lymphatic and in the thoracic duct is a low volume, low pressure. So by clipping the thoracic duct very high up, so in a way distally, you create a system that is no flow and high pressure. Hence, you can see in this image here, a very congested and swollen thoracic duct. And what that does is not only makes very, very easy to identify the thoracic duct, but as you will see shortly, it will allow also to identify accessory branches. This is the normal anatomy. This is the clipping of the duct in the lower part of the chest. But we know well that the anatomy of the thoracic duct is variable, is inconsistent. This is the first of the accessory duct that I've seen. We are in the lower part of the chest, and you can see a nice duct that cut across. If we cause an injury of the thoracic duct, this is what we see. And this is what we wouldn't see unless the thoracic duct is clipped very high in the upper part of the chest. So that's the importance of changing the low pressure to high pressure. More images of accessory duct. You can see at the top of the screen the azygos vein that has been divided and stitched to the spine. And this is an accessory duct that literally cut across nearly in the upper part of the chest. This is another accessory duct that is literally a few centimeters distal to the azygos vein. So these are in the series that I'm showing you. These are 3 of them three of the accessory duct identified. So I've started doing these when I was doing minimal invasive oesophagectomy. So in 2021, I mean, before 2021, then it did continue with a robotic experience. At the moment, you know, we got this in 8. It's been a reasonably prospective study, this one. There has been a few patients who are not included in this study, mainly because ICG availability or 3-stage oesophagectomy that doesn't allow the injection in the mesentery before the dissection of the chest, and so on. But the important thing is that, you know, there were no complications associated to the injection, so it was always successful. The thoracic duct was identified in over 90% of the patient, and in that 3 patients who was not identified, I did a mistake. I acquired the image too quickly, because in less than an hour from the injection in the mesentery, the thoracic duct may not be as visible as after 1 hour. Abnormal duct seen in 3 patients out of 36, and this 8% is very, very close to the incidence of chyle leaks. So suggesting that is all accessory duct instead of direct injury. And in this series of 36 cases, there was 1 chyle leak that didn't need any intervention. The other application of the ICG in esophagogastric is perfusion of the gastric conduit. And this is a terrible pain, unfortunately, because you know, the gastric conduit is a pedicle conduit. Pedicle conduit in all the surgical specialty are the worst conduits, are the worst flaps in the pedicle flap, because the perfusion is patchy and it depends on the submucosal vascularity. So obviously we want to do it, you know, it's very easy. You inject, you ask the anesthetist to inject a bolus of 2 mL of ICG through the central line, and very quickly it will be visible in all the vessels that you got in front of you. You know, poor perfusion is associated with anastomotic leaks, and here I stress that may help identifying the best perfused part of the gastric conduit. It may help identifying high-risk anastomosis by studying the perfusion pattern. So this is actually a very interesting aspect of ICG, because it's not just seeing a vessel filling up with green or the stomach turning green, is also the physiology of the conduit that makes a difference in terms of the speed of filling and the emptying. And I'll show you videos, short clip of ICG perfusion. This is actually the stomach. I have just removed the spleen in this patient because of bleeding from the spleen. So the oesophagectomy have been abandoned. And before bailing out and taking all the instruments out, I decided to do an ICG, pure anatomical study. I'm not interested in perfusion. I just want to know if the right gastric epiploic arcade is intact, in case the patient was going to go ahead with an oesophagectomy, at second stage. This is the perfusion. At the bottom, you can see, sorry, at the top, you can see the aorta here. You can see the vertebral branches at the top. As soon as you inject, you've seen filling of the vertebral branches as they arise from the aorta. And here you can see on the gastric conduit, posterior wall seems to pink up reasonably. You can see the vessels on the greater curvature that are surrounded by fat. And thanks to that ICG test, I decide more or less where to divide the gastric conduit. Similar application is at the end of the anastomosis. So you have divided the esophagus, you've done your anastomosis, and at this stage, you can ask the anesthetist to inject another bolus of ICG. And as you will see, the anastomosis in this case, well, the gastric conduit shows a good uptake. There are vessels in the greater curvature omentum that fill up with blood. So one can say, okay, I'm reasonably happy with the perfusion of these. I couldn't have done anything different, and I'm happy with that. But with regards to the incidence of anastomotic leak, I think that there are so many other factors that are intrinsic of the patients, specific of the postoperative recovery, that actually may play probably an equally important part into the anastomotic leaks. So the perfusion is not certainly the ICG perfusion is certainly not going to be a solution for anastomotic leak. It can help. I've told you airway injury is a terrible complication, although rare. By nebulizing ICG into the airways, we'll be able to identify the wall of trachea. So here you can see this is a large subcarinal lymph node. And here I'm doing the dissection in front of the posterior wall of the trachea. This is the carina. This is the left main bronchus. And on this side, there will be the right main bronchus. And you can see that, you do a bit of dissection, and then you, by highlighting, turning on the ICG, you will be able to have another, another support of the ICG of the airways. Do I believe that this is, a game changer as for the thoracic duct? Absolutely not. In the sense that, with the robotic and minimal invasive surgery, the quality of the view is so good that you shouldn't be needing any further intervention or methodology to see the airways. If you make a hole, the anesthetist will tell you straight away, because there will be a major leak. But I think that in salvage resection, so post-chemoradiotherapy, where there will be quite a lot of scar tissue, or in those patients who actually have an incredible response to neoadjuvant treatment, and this all area, every single lymph nodes or the primary tumor will be involved in quite an extensive inflammatory process, I think it could be a useful way of guiding your surgery. I've reached nearly my conclusion. So ICG fluorescence for OG, ICG thoracic duct identification, I think we are at the stage of just disseminating this procedure that is very well standardized and very effective. ICG perfusion, I think has got huge potential, but until when we're going to have a quantitative assessment of the ICG, we are going to be missing the baseline, and that is a major weakness. The role of the physiology of the patients will play an important part. For example, if you give ICG with a systolic blood pressure of 80, expect a very poor perfusion. So you have to standardize also the physiology with anesthetists. Another problem comes from the fact that multiple platforms, Storz, Stryker, Intuitive, they all have developed this technology, and there will not be they will not use the same standards. ICG airways could be useful for small cases, but probably this is the real future of ICG, and is in cancer surgery and the main nodal mapping. So by injecting ICG in the fourth quadrant of the tumor, we'll be able hopefully to identify, the very, very important nodes that are the ones that are left inside. We can count lymph nodes and congratulate ourselves. But if we leave the lymph node that matter, then it won't be good for the patient. It will give us more understanding of lymphatic drainage and basins, and it will challenge probably the standardized D2 nodal dissection towards probably a more tailored nodal dissection. Thank you very much.
So my name is Geoffrey Roberts. I'm one of the relatively new emergency general and upper GI surgeons at the JR. We're going to be talking today about endoscopic management of upper GI perforations, which is a relatively new and developing field, and how that fits into classic treatment pathways of thoracotomy or laparotomy, and where it is and isn't beneficial. Then we'll have a bit of a discussion of case reports. So first of all, I'm not going to make any money out of this talk. That was an important thing to say, because I'm going to talk a bit about devices. In terms of what we'll look at, we'll talk about the general principles of endoscopic management of perforations, how it works. We'll have a look through a case with some good pictures, and then we'll talk about when to use and when not to use, because at some point in this I'll start to sound like a man with a hammer, and every problem looks like a nail, and I can assure you that not every problem is treatable with a vacuum device. So first of all, mostly what we're talking about here is Boerhaave syndrome, classically described as from the death of the Grand Admiral of the Dutch fleet, who gorged, then vomited, and then ruptured his esophagus and died, but named for the Dutch physician. And really, in the UK, we talk about a 20% all-comers mortality for Boerhaave syndrome. So it is a big problem with a high mortality risk, and often happens in people who are not in the rudest of health. General principle of management of these patients is really as with any other surgical sepsis pathology. So resuscitation, get rid of the ongoing sepsis, control any leakage, treat the underlying physiology, manage nutrition, and then promote healing. And that's a multidisciplinary approach, and this group almost always requires significant intensive care and anaesthetic support, because these patients are fantastically unwell. And standard treatment options at the moment are, let's pull this out of the way, thoracotomy or thoracoscopy, debridement, control of the hole with a surgical T-tube to make a controlled fistula, then abdominal access for nutrition, a stent, which sort of was favourable 10, 15 years ago, so placing a fully covered metal stent, which allows for coverage of the hole, but doesn't necessarily allow for drainage of the problem. And I'm not really going to talk about stents today, but to me, the main problem with stents is they're designed for treatment of strictures. They apply radial force onto a tight stricture in the gullet, and that's not what they're not designed to cover a hole, particularly in a non-strictured esophagus. And then endoscopic vacuum therapy, which we are going to talk about today, which is placement of a sponge on a tube through the nose to a vacuum device to allow ongoing suction drainage of either a cavity or the lumen of the esophagus, or whatever organ we're treating. So how do you do it? We talk about two approaches, either intracavity or I refer to that as extraluminal, so sponge outside the lumen of the organ you're trying to treat, or intraluminal, sponge inside the organ you're trying to treat. So you do an endoscopy under general anaesthetic. You place a sponge on a tube into the cavity, bring out the other end through the nose. I'll talk you through the devices we use to do it. Attach it to a standard vac pump at 125, so the same you'd use for a wound or for an abthera in the abdomen, and then change it every 3 or 4 days until it's healed. And the key principles of this, first of all, the size of the hole actually isn't that important when you're treating things endoscopically. It's the size of the cavity and getting drainage of the cavity. The hole will heal once the sepsis is controlled. One of the big benefits of endoscopic management of perforations is that every 2 or 3 days you put a gastroscope down and you wash out an abscess cavity. So you can have ongoing and recurrent lavage of mediastinal or pleural sepsis. And the negative pressure allows for good drainage of cavity and control of sepsis. It promotes healing as in any other part of the body, and it does support closure of the defect. And I talk about 2 phases of recovery, and we'll look at those as we go through pictures. But basically, initially, you have control of the infection. And then once infection is controlled, things start to heal and you see granulation of your cavity. And as time goes on, your location of where you put your sponge moves from being outside the lumen to control the sepsis to inside the lumen to promote healing of the hole. There's 2 rough ways of making do. There's a device called an esosponge. And if I flip between talking about esosponge and endovac today, it's just the 2 different devices. It's the same thing. Or there is a means for making one with an NG tube, some black foam and some stitches. And they both have pros and cons in how those devices are put together. I'm not going to labour the point today, but they're both have their role. I'm going to apologise for stealing a case series from Cambridge, which is where I did my fellowship and trained, because that's why I can talk about with my hand on my heart. So actually, the case series is up at about 50 now. I just looked through the spreadsheet, but this is the data I've got. So nearly 40 patients with about a 13% mortality. And the thing to say about these 40 patients is they are 40 all-comers. So when places tend to start doing this, they tend to take the people who are not physiologically suitable for a thoracotomy or would otherwise have been palliated, and they offer them endovac treatment first. So these are often quite frail patients who would have been turned down for curative treatment and palliated at the point of diagnosis, with an all-comer mortality of about 13%, which is reasonably good for esophageal perforation in this patient group. So we'll talk about a case series that we've managed here in Oxford recently. He's probably going home this weekend, so let's just sort of give the ending away before we start. So 63-year-old, actually very fit man, came in with a short history of vomiting, and CT with oral contrast showed an esophageal perforation. We can see here, we have this. We don't have this pointer, do we? Anyway, we can see contrast outside the esophagus, no big pleural effusions. Actually, he was relatively physiologically intact when he came in. So he had bilateral chest drains. He had a sponge, I don't have any photos to start with, just put in the lumen of the esophagus because there was a small hole that they couldn't get through, and then a feeding tube placed. Unfortunately, by day 4, he'd massively fallen off his perch, been re-intubated, and become quite septic. And we can see the CT is perhaps a little bit worse than on admission. And if we look at, so this is an endoscopy on intensive care here at the JR. And what you're seeing is me trying to poke the tip of the endoscope out into the mediastinum and pleura. What you can see there on the right is the back of the heart, posterior pericardium, and that's looking upwards into mediastinum and left chest. And we can see extensive mediastinal contamination. And if I played that for another 5 minutes or another half hour, you'd see us doing an extensive lavage, retrieval of foreign bodies, and clean out. What you get at the end of that, on the far right, you can see that the 2 litres of sort of black gunk that we pulled out of his mediastinum, and relatively cleaner picture. The picture on the left is the endoscope going out through the hole in the esophagus, and all of that is actually in the patient's chest. So we've done a full mediastinal lavage. I'll show you how we do a sponge in a moment, but coming back 4 days later, less mucky, but still mucky. But again, we just do another lavage, and he's not doing that great from a respiratory point of view at this point. He's certainly never going to be suitable for a thoracotomy or a thoracoscopy now. And actually try avoid doing a thoracotomy or a thoracoscopy at this point, because the lung is very sticky. You'll have significant air leaks, and it'll be very difficult to close down the cavity and the defect with a high risk of developing an airway fistula. So at this point, this is a good example of a video of how an endovac goes in. So just at the bottom of that picture, you can see a sort of little sausage of spongy stuff that's covered in the same, lack of a better word, gunk from the chest, that's been placed after the washout. And you'll see us withdrawing the endoscope, leaving that in place in the cavity. That's the edges of the defect in the esophagus there. And as we turn the suction on, we can see the cavity collapses down onto the sponge. and that's then left in place and attached to suction over the course of the next few days. Oh, that's the point. Wonderful, thank you. So unfortunately, at this point, he continued to be quite septic despite good control of the mediastinum. And we can see here he's got this, what we refer to as almost a dumbbell abscess. So if you control the mediastinum well, and the tract from the mediastinum to another cavity elsewhere collapses, you end up with a satellite or dumbbell abscess. Now, the big problem here was this wasn't reachable via interventional radiology. There was always lung overlying it, so he'd had a high risk of lung injury from external drainage. So again, here is where actually having an endoscopic approach is often quite helpful. I can't quite show it, but we go down through the hole and actually navigate the endoscope up into that cavity and drain it. So at this point, you can see us going up through a slightly different route into, and eventually we'll get into that cavity, drain a large chunk of pus. Actually became incredibly unwell at this point, as you'd expect from draining a large cavity with gram-negative septicemia. But because we're on intensive care, he was in exactly the right place to get his physiology back. And again, I think at this point we put 2 sponges in because the cavity remained quite big and we wanted really good collection. So we just ran 1 tube out each nose onto 2 different devices to get really good control. So that was sort of the nadir of his course of treatment. And over the course of the next 20 days, we can see a progressively improving cavity. Here we can see a sponge just before it's sucked on. But progressively granulating multi. So this is all cavity. This is all looking out through the esophagus into the mediastinum and the pleura. And we can see progressively granulating, and then you'll have to take my word for it, shrinking cavity, because the perspective's not the same on each of them. And this is with twice weekly changes, and this slowly gets better. And over the course of this period of time, he went from being on sort of lung protection strategy with an FiO2 of 0.7, 0.8. There was a brief discussion about ECMO at one point. He was that unwell, to actually being, by this point, being awake, standing by the bed with an ET tube in, still with a reasonable amount of respiratory support, because he'd had terrible ARDS and mediastinitis. And actually, by day 42, the hole had completely collapsed. So we can see the hole here, but we can't get a scope through it, so it's less than 1 centimetre in size. We can see a small cavity distal to it just here on the CT scan. He had a tracheostomy placed to help his respiratory wean, and he was doing laps of intensive care with his endovac in and a trach in. By day 49, that's all that we could see of the hole in the esophagus. There's a good lumen elsewhere, so there's no stricture developed, and he was rehabilitating really well. And then by day 55, which is this week, we removed the endovac into the CT with oral contrast, and that there is probably a tiny trickle of contrast, leaving his esophagus out into a tiny sinus. And at that point, they can really get back onto fluids and almost eat and drink, because that's going to be an epithelialized tract that's more like a diverticulum than a hole in the esophagus. And he's probably going home this weekend. So what does endovac therapy offer us? And I'll talk a little bit about where it might fit into treatment pathways. So resuscitation, it can be done in intensive care. I've done these on patients who have been peri-arrest and even had respiratory arrests around the time of treatment in intensive care. They allow for recurrent lavage and drainage of the collection and ongoing suction drainage in between washes. They're really good strategy for controlling a really mucky cavity in a really difficult to reach place. You avoid the thoracoscopy and period of single lung ventilation. Admittedly, that's a one-off hit, but sometimes people at the point of presentation are really going to struggle to get through that. Nutrition is just the same as with any treatment, and there's the sort of well-described benefits of negative pressure therapy in soft tissue wound healing. So where does it place droop down? This is a speculative side, because I don't think anyone really knows the answer here. There haven't been any big trials. Some units, if you go into every esophageal unit in the UK, you'll have a different pathway for management of this. I sometimes joke it's a bit like hemorrhoids, in that there's half a dozen different treatments and no one knows which one's best. So you work with what you have collective experience of. I think reasonable things to say are, if you get someone who's early and well and physiologically relatively intact, and the esophagus is, you can reach it and you can stitch it and you can be comfortable that it's likely to heal, you should probably be surgically operating on them and repairing it. If you get someone who's in a heap, that's really going to really struggle to get through a thoracotomy, or their lungs are going to be stuck because it's 3 or 4 days down the line, or you can't reach the bit of the esophagus because it's an anatomically challenging area to get, then endoscopic therapy is your friend. And then most people are somewhere in the middle, and it's going to depend a little bit on individual patient development. And I'm just going to stretch out a little bit from Borjas to somewhere else recently, just to talk about other anatomically challenging areas. So this shows we can use elsewhere. So this is a D2, duodenum second part, periampulary diverticulum lid perforated. And these are really difficult to manage because you can't radiologically drain them. You can't surgically get to them without getting into tiger territory around the pancreas and various hepatic vessels. And often treatment is long-term antibiotics and about a month worth of TPN while it all settles down. If you can get a sponge just into the lumen of the duodenum for a week, it will suck all the gunk out, and it will heal up. And this patient had a week of endovac therapy and then went home remarkably well. And I think we've got a case series of 3 of those that we've treated like this that have done really well with very little intervention. And this rather gruesome picture is an endoscopic perforation of the cricopharyngeus. So that esophagus should be up there, and that's esophagus there. And this is all the way down posterior mediastinum from a big endoscopic perforation, which we treated endoscopically, because to try and get to that surgically for a sutured repair would have been very challenging. And she did very well without any major intervention apart from a mini laparotomy to place her feeding tubes. But when you shouldn't use it, so it's never going to work in an established fistula. It's not going to get rid of epithelialized fistula tract. I think people have tried it on necrotic pancreas, but the problem is you're sitting it basically on splenic vein then, and if you do that, you're liable to cause spectacular complications. And that's the same with esophageal varices. I'd be reluctant to place it on a varicide on a hepatic encephalopathy esophagus because your risk of precipitating a massive bleed would be quite high. Thank you.
There we go. So, as I say, there's lots of emerging treatments here. Immunotherapy is probably the most exciting one, which is why I've kind of focused on it here. And the immunotherapy is really designed to bind and block the kind of don't eat me signals on cancer so that your own immune system can target it, but very simply. The survival plot on the left, on the right, sorry, of that screen shows data from Oxford from our prospectively maintained CODA database of cancer outcomes. And really what I want to get across here, these are all patients that have had oesophagectomies that, even with all of the various things that are going on and advancements that we've had, still the absolutely key thing that makes a difference in terms of your survival is the stage that you are at and your pathological sort of results. So as you can see, their stage 1s do extremely well, but they rarely get surgery. Most of those are managed endoscopically. Stage 2s do pretty well, and then stage 3 and 4 do really terribly. What you can't see from that plot is how many people are in each stage, and actually about 80% are in stage 3 or above at diagnosis. So in terms of our sort of cure rates, we are dealing with the lower sort of curves on that survival plot. So the question really is, where can we impact on cure in esophageal cancer? Obviously, if we can diagnose earlier, then we are looking at earlier stage disease, but I'm not going to talk too much about that because we're surgeons and we get given the patients that we get. So really, our opportunities are sort of displayed graphically in this cartoon down here. We can characterize tumours up front and think what therapy sort of fits, personalises to that particular treatment. We could think halfway through that therapy before surgery, sort of neoadjuvant phase, is it working? Should we switch what we're doing? Just before surgery, we can think, should we be going ahead? Is there other things we can do to optimize here? Or add in extra adjuvant treatments at this point? And then in terms of sort of follow-up phase, can we pick up recurrence? Can we aggressively manage recurrence and treat it with curative intent? Okay. So, starting at the beginning of that, characterizing tumours at baseline, who does respond to immunotherapy, which is coming online probably later this year or maybe next year as a standard of care neoadjuvant treatment for esophageal cancer. Currently, we use a couple of histological scores. but they are used to access treatment at the moment, but they're not reliably predictive in the trial data that we have. We know that certain subtypes of esophageal cancer do respond very well. So microsatellite instability and Epstein-Barr virus positive cancers all respond really well to immunotherapy, very high complete response rates. But the problem there is that they're extremely rare in esophageal. And actually, so the plot on the top here is a waterfall plot that just shows sort of tumor size in response to immunotherapy. And as your tumor size sort of gets less, which is the ones on the right, this is where all of the MSI or EBV positive cancers sit. And your most common esophageal cancers all just got bigger. Okay. Data on the bottom is from TCGA, which is the sort of major American sequencing effort to characterize cancers of all types, and specifically to esophageal. In their data, it was published quite a while ago now, there weren't really any MSI high or EBV positives in their data set. So you know, we need something more, essentially. Okay. Our next sort of point where we could consider changing things is really just, you know, before surgery. Can we adjust what we do after surgery to try and achieve cure in people who haven't quite got the result we want pathologically from the resection? That's recently just been published in the Vestige trial, which was run by Lizzie Smith, one of the new oncologists in the trust here. And what they did was take people who had like poor features in their post-op pathology and then gave them immunotherapy after surgery rather than continuing the standard of care treatment. And actually that didn't make any difference. So again, we probably have a lack of awareness of the cancer subtype in terms of who's going to respond to immunotherapy. So you know, we have to keep looking. So in Oxford, we designed the Ludwig trial, which is a phase 2 trial. And we designed this really as a vehicle to specifically look at who's going to respond to immunotherapy. So there was a huge sort of translational scientific input to the trial design. It's quite a complicated trial, but essentially it was set into a sort of a palliative cohorts, and those are the top two. And they got immunotherapy for 4 weeks alone. Then they went on to palliative chemo alongside immunotherapy and then follow-up. And patients were sampled at various sort of every key time point along the way with blood and where possible tissue. And then later on, once we established that was a safe treatment course, we introduced that into surgical patients. So they had 4 weeks of immunotherapy, and then they went on to some sort of standard of care neoadjuvant treatment, either chemo or chemoradiotherapy. And they had their surgery and follow up thereafter. And our key questions here were, you know, what predicts response, you know, into this sort of regime. So in our, you know, first things in our palliative cohorts, which was 33 patients, we did a whole load of sequencing tests. So we looked at RNA sequencing, single cell and whole genomes. And we really wanted to investigate the kind of experimental predictors of response that are already known about, and some of them, and come up with our own predictors as well. Our sort of the way we really sampled from these was endoscopically, and we took biopsy from normal sites as well as the tumor. We took quite a few biopsies and then split them up for each of those assays. In terms of applying the existing predictors that we know about, we looked at PD-L1 expression, which is one of the things currently used in clinical practice to access immunotherapy, and didn't find any association with overall survival or progression-free survival. One of the more experimental things is looking at the total number of mutations, somatic mutations across your tumor, and that's called tumor mutational burden. And we know that high tumor mutational burden ones tend to respond to immunotherapy, and we did see that in this trial. We saw a significant survival advantage in people with high tumor mutational burden. Just for context, if you look in non-immunotherapy trials that have been run, we don't see that effect. So this is an immune therapy specific finding. Of course, we were very excited then apply our own sort of techniques to this. So we, through quite a convoluted process, we used a single cell RNA-seq map. We then used our bulk RNA sequencing to deconvolute that and really try and work out across the whole cohort what cell types are representing these tumors at baseline. And from that, we came up with tumor monocyte content, so TMC this time. And what we found was that TMC was highly predictive of progression-free survival and clinical benefit, which we've termed as 12 months progression-free survival. Okay. Importantly, this was additive to tumor mutational burden as well. So they weren't saying the same thing. It's not the same patients twice. And if you had both high mutational burden and a high monocyte content, we saw durable response. And we're up to 7 years follow-up for some of these palliative patients now with esophageal cancer. So obviously, as a surgeon, I'm much more interested in the surgical cohorts. So these are the kind of up to stage 4B group. And we had 35 patients that went through those treatment pathways. In general, treatments were well tolerated. We didn't have any particular safety concerns at trial. A lot of the patients we recruited were stage 3 disease, as we'd expect. And when we propensity score matched survival against our CODA, our own sort of in-house database, we found just about a significant survival advantage for people who went through this treatment. We also saw that the 2-year survival rates through this exceeded that of the published trials for the standard of care treatments. The next thing we wanted to do is test really whether this monocyte count, TMC, predicted the same thing in this cohort, or was it a palliative only thing? And actually, if anything, we saw this was a stronger predictor of survival in this group. And if we look at our TMC high patients on the survival curve, we saw phenomenal survival, considering these are mostly stage 3 patients. We've obviously taken that a little further on. With some excellent work by Hannah, who's one of the PhD students and a medical student, due to return to medical school later this year. And she has come up with a core gene set, mainly myeloid lineage predictors, which are associated with significantly associated with overall survival and a major pathological response. So the next issue we have here is really, how do we know when we start a therapy, we can do something to characterize it, but at the moment we're not really in a position to say who definitely will or won't respond from baseline. So we need some sort of metric, some measure that the drugs we're giving are actually getting into tumor and having some effect. So with that, we developed, or Tom Carroll, another PhD student I worked with, we developed something called the INSIGHT score, which is an acronym, and I can never remember what it stands for. But INSIGHT is a sort of gene signature which just associates with tumor shrinkage on that specific 4-week period where patients just had immunotherapy. And we found that not only was that associated with tumor shrinkage in our trial, but when we looked at it in other trials, in melanoma and other cancers, it was associated with survival as well. Obviously, taking tissue biopsies to measure response is a bit annoying for patients and not that flexible and agile, especially in a palliative setting. So the next sort of level that we were really interested in is, can we do this in blood? Can we monitor tumor response and sort of monitor cancer in blood? And for that, we used a method called teta-assisted pyridine borane sequencing, or TAPS for short. And that was developed by a scientist called Chun-Chao Song, who I work with in the Ludwig Institute. And essentially, it's a test that looks for methylation as a way of identifying circulating tumor DNA in the bloodstream. Okay, he's already demonstrated that this is a highly sensitive way of detecting cancer, in liver and pancreas tumors. And part of that is because it gives you lots of different analytical methodologies that you can apply. But what I was interested in is, can we get prognostic detail from actually looking at the quantitative levels of circulating tumor DNA by this method as you go through neoadjuvant treatment? So the way we got to this was quite complicated. And if Phil, the PhD student that worked on this, is out there in the ether, I apologise, because he put so much work into this and I'm summarising it in an incredibly brutal fashion. But essentially, we took some tissue from esophageal cancer patients, from tumours and from normal controls, and we developed a methylation signature using this method, which was tumour specific and was present in all esophageal adenocarcinomas. What we then did was look for the presence of that signature in blood, in sort of cell-free DNA, which we extracted from the bloodstream, from plasma samples of patients with esophageal cancer. What we can then do is model the mixture of normal and tumour DNA and actually come up with a metric which tells us how present is circulating tumour DNA in these patients. And that what that allows us to do is not just give a binary yes there's cancer or no there's not, but what is the cancer activity actually doing in a sort of relative real-time basis. And we've called that TMD, tumour methylation detected. Okay. So, is TMD, is this a biomarker for progression? Well, we applied it at baseline and then after 4 weeks of immunotherapy and then compared the two readings, and we correlated that to survival and against the radiological criteria for response, which is our current sort of gold standard for how we monitor response. And I think so in the top sort of waterfall plots, what you can see is on the left is a sort of change from baseline in patients in terms of their TMD. So if it went down, that's a good thing. If it went up, that's a bad thing. And on the right side, we can see overlaying that with the CT-based response criteria. And I think what's clear here is that the blue patients had a clinical benefit and the orange ones didn't. And I think we see a much clearer discrimination when we apply our kind of TAPS or TMD as our biomarker of progression. We saw a much greater accuracy in terms of applying this than using CT criterion, in terms of a sensitivity and specificity analysis. And it also outperforms some other blood-based measures that get used. In terms of survival, again, we saw a massively improved survival advantage in patients that had a reduction in their TMD over that initial period. And then just before I finish, this isn't quite related to immunotherapy prediction, but obviously the next question is can we detect recurrence afterwards? And Shiraz Markar's leading a major, now international study looking at recurrence detection with radiological imaging mostly. And what we're trying to do is build in TAPS as a method for cancer detection in the post-op phase. To do that, we've really looked at diluting in silico our cancer samples to see just how little cancer needs to be around for us to detect it. And we're currently down to about 3% of the original plasma cancer concentration to actually still be able to make a significant detection rate. So we're quite optimistic this will be a highly sensitive test for recurrent cancer, which is something we'll be testing in the coming couple of years. So yeah, just to summarize, we've come up with TMB, which is already known, but we validated in our experiments as a predictor of immuno. TMC is our new one, and that's what we published earlier, in 2023 in Cancer Cell. And TMD is what we're working on now, and we found that associated clinical benefit, from blood-based measurement. So just thanks to everyone that's involved in the study groups and various funders that are on. Thank you.